This is a quick video about parenchymal disease of kidney to satisfy some of the objectives for this session. I will go over them and we will have a discussion session when we meet together. Okay, to start with, the kidney consists of different components from histological, pathological point of disease. We can divide the functional units of the kidney into four components: the glomeruli, the tubules, the interstitium, and the vessels and the vascular component. So from this analysis, one might think of any disorder of the kidney to be involving one or more of these components. So if we have someone who is sick and he has kidney disease, his disease might be glomerular, or tubule, disease of tubule, or disease of interstitium, or disease of the blood vessel, or of course a combination of these different components. We will not go into details of all components. We will just have a quick overview on glomerular disease. Not even details of glomerular disease, we will have overview of it. So glomerular disease constitutes some of the major problems in nephrology. There is some confusion in the terminology, especially if you come across this term to the first time. But with reading around these topics, you will be familiar with the terms and hopefully not confused anymore. The term glomerulonephritis literally means inflammation of the glomerulus. And this means that the cause is not single or clear or determined. The term includes any inflammation of the glomeruli due to any other causes, and obviously there are many other causes of glomerulonephritis. These causes include a primary disease of the glomeruli itself, themselves, or secondary disease, someone who has systemic disorder, typically commonly like diabetes or hypertension or lupus, systemic lupus, and secondarily have disease of the kidney. The term glomerulopathy is more restricted to primary disease of the glomeruli. So if we consider, or if we know for sure that the disease that the patient has is really primary disease, we might use the term glomerulopathy instead of the general term glomerulonephritis. However, in any case, you will find people using this term interchangeably, meaning the same thing. So there is some overlap between these terms, although I try to delineate the differences between these two terms. Glomeruli may be injured by a variety of factors. And this is something that you need to keep in your mind from the beginning. So as I just mentioned, glomerulonephritis is inflammation due to many causes. I'm just saying it in a different wording. Glomeruli may be injured by a variety of factors. When you have a patient complaining of symptoms and signs of glomerular disease, at the beginning, the cause might not be clear or obvious. We deal with clinical disease first, then we try to find out what is the pathological background that result in the disease. Most of the glomerular disease are immunologically mediated. We will very quick talk about the types of immune mediated disorders result in glomerular disease. This list might not make sense at the beginning, but this slide just to show you in red that there are two groups of glomerular disease: the primary glomerular disease and the secondary glomerulopathy or glomerular disease. Um, Secondaries meaning that the patient has obvious disease that secondarily involve the kidney. Common: systemic lupus erythematosus, diabetes mellitus, good pasture, and you can read the list. It's long list. In these cases, the cause is known, or the pathogenesis is known. The patient already has a disease that is secondarily affecting the kidney. In the first group, the primary glomerular disease, there is no underlying illness, so the person is essentially healthy with no previous disease, and suddenly he or she develops some kind of renal disease that shows some glomerular injury. We will come across some of these terms, however, not into details. This session is really an overview of the topic. I'll just mention very quick words for each term. Minimal change disease, as the term implies, there is really minor insult, minimal change, minor insult to the kidney that typically result in injury to the glomeruli with protein loss. So the patient starts to lose proteins in the in the urine. Sorry. Typically, these patients present with nephrotic syndrome. We will discuss in few minutes the details of nephrotic syndrome, but it suffices for now just to remember minimal change. There is minor insult with loss of protein in the urine, so the patient has proteinuria with loss of protein. Why we call it minimal? In a typical pathological exam of kidney biopsy, we do different techniques to check or to examine the kidney, and specifically the glomeruli. There are three main techniques that routinely done: examination by light microscopy, examination by immunofluorescence to see any deposits, immunofluorescent deposits within the glomeruli, and the third technique is examination by electron microscopy, again to show deposits that can be seen, or to see some changes in the structures of the cells within the glomeruli and the basement membrane. In minimal change, why we call it minimal change? Because there is no changes by electron microscopy that can be identified. There are no changes by immunofluorescence that can be seen. The only changes that can be seen are detected by electron microscopy. So that's why it is called minimal change. There is very minor change that can be detected pathologically by electron microscopy only, while the light microscopy and the immunofluorescence are normal. I will not go into details of the findings of minimal change. We might discuss it in another session, but for now it's enough to just remember this is what we see in minimal change. The term focal segmental glomerulonephritis or glomerulosclerosis, the better term, focal segmental glomerulosclerosis, is considered as an advanced stage of glomerular disease that can be proceeded with other primary diseases or other secondary diseases, but it is essentially not specific. Focal segmental glomerulosclerosis is a kind of advanced disease that is a common pathway for many different kind of diseases. However, there is some relation between minimal change and focal segmental glomerulosclerosis. Some people, experts, describes that these two entities might be ends of the same spectrum of disease. Patient might present early on with minimal change, then the disease progresses until the patient develops focal segmental glomerulosclerosis. Um, uh, Defining the term, just this is terminology, very simple terminology. Focal is opposite to diffuse, meaning that some of the glomeruli, if we have in the biopsy, for example, 10 glomeruli, focal meaning some of these 10, 3 or 4 out of 10 glomeruli have some injury. As opposed to diffuse, diffuse mean all the 10 glomeruli have some injury. So focal is opposite to diffuse. Segmental is opposite to global. These are the terms that are used to describe the glomerulus. Imagining that the glomerulus is a round structure, sphere like a globe. Segmental meaning it means part of the sphere of the glomerulus, and the opposite is global, which means the entire glomerulus shows some disease. Okay, enough for this, because we will not really go into the details of these entities, but it is enough just to describe the terms, since we have listed them for you here. Okay, so in reality, clinicians deal with clinical diseases, syndromes, rather than, at least at the beginning, with pathological entities. So before clinician knows what's going on in the kidney, he has to really deal with patients. So patients present with different types of clinical presentation, and this list summarize the most common presentations of kidney diseases in general, and more specifically what we are concerned with here is glomerular disease. Not all the list are glomerular disease, but these are common presentation of kidney diseases. Our focus in this session is the more details about nephritic syndrome and nephrotic syndrome, and we will come across these as we progress in our talk. So we will come back to these. The term asymptomatic hematuria or proteinuria is really obvious to understand. The patient does not complain. However, by examination, he has or she has hematuria, blood in the urine, usually microscopic, that the patient does not notice any change in the color or any change in the urine. Or asymptomatic proteinuria, again, the patient does not notice any changes, but it is detected if urinalysis is done. We find protein. So this is one of the clinical presentations. Rapidly progressive glomerulonephritis is a little bit confusing term, but it means, what does it mean? It means that the patient typically present with nephritic syndrome. However, the patient progresses quickly to acute renal failure. So this is the meaning of rapidly progressive glomerulonephritis. The patient present first with nephritic syndrome, but in few days or few weeks, the patient progresses to acute renal failure. Usually, rapidly progressive glomerulonephritis is related to a pathological entity, a pathological finding, which we call crescentic glomerulonephritis. This term was not written here. It refers to a typical finding of glomeruli where we see proliferation of cells that looks like a crescent. Back to the idea of the globe, the glomerulus looks like a sphere, a globe like the earth, and on top there is a crescent like moon crescent, due to proliferation of cells within the Bowman capsule. For now, we will not really go into details more than this in this talk. It is just enough for you to understand the term rapidly progressive glomerulonephritis, that it is related to what is called crescentic glomerulonephritis. Acute renal failure, from the term, it simply means the kidney is not functioning as it is supposed to be, and if the kidney does not function, the patient will have either oliguria or anuria, so no urine output at all, or very small amount of urine output, with increased level in the blood of urea and creatinine. So azotemia is increasing level of urea in the blood. The term chronic renal failure by itself does not mean or does not indicate the cause. There are many causes of chronic renal failure, but it is an end stage where the kidney components are injured and destructed with a final loss of function, resulting in essentially renal failure. For now, urinary tract infection is not, it is different. We might discuss this in our discussion when we meet, and nephrolithiasis, renal stones, we might discuss quickly what are the common clinical presentation of these two entities. However, the focus now on the glomerular disease, nephrotic and nephritic syndrome. So back to glomerular disease. As I mentioned earlier, glomerular disease can be primary disease where the patient is previously healthy and he just developed a renal disease where the glomeruli are affected. Or it can be secondary where the patient has some sort of disease. Common diseases are immune mediated disease like systemic lupus, and secondarily the kidney is affected. What is the pathogenesis? Almost all glomerular diseases are related to immune mediated pathogenesis. So there is immune mechanism underlie most form of primary glomerulopathies and many secondary glomerular disease. Even the secondary diseases like glomerular disease related to lupus nephritis is also mediated by immune disorders. This is just a list of the types of immune mediated mechanism. Again, I will not go into details of each one, describing what happens in each of these pathogenesis. However, it suffices just to consider the different types of these immune mediated disease. If you remember, antibody mediated is a typical type 2 hypersensitivity reaction where there is antigen antibody reaction. So in the kidney there is a molecule that is considered antigen, and there is antibody coming from the circulation that binds to this antigen, and we call it antibody mediated immune disease. A typical example is type 2 hypersensitivity reaction. In this circulating immune complex is a typical type 3 hypersensitivity reaction where we have antigen antibody complex circulating in the blood, then deposited in the kidney, resulting in injury of the kidney. In between those two, the antibody mediated and the circulating antibody, there is a type that is discussed in the literature, and they name it in situ immune complex deposition. So the immune complex is not circulating, it forms in situ within the kidney. So this is another type of immune mediated disorder. Another type, cytotoxic cell mediated immune injury. So the cell reaction, the cellular reaction, is the responsible mechanism for the injury, and it might not be related to antibodies. Activation of complement pathway is a finding in some of the glomerular disease, where the complement activation result in inflammation and injury of the kidney. This is a common sequence of events from pathology point of view that happens in many glomerular disease. This pathway is simply several steps that follows each other, a sequence of event. So at the beginning, it starts with antigen or antibody or immune complex deposition within the kidney. Remember, in the kidney we are looking at structure. The important structure in this context is the filtration within the glomeruli, where there is basement membrane in the middle, epithelial cells from one side, epithelial cells of the Bowman capsule and the tubules, and from the other side, endothelial cells of capillary. So fluids, electrolytes has to pass through this structure. They have to pass through endothelial cells, basement membrane, and epithelial cells. So in this tiny structure, all the pathogenesis occur. So if there is antigen antibody complex deposits, this is the first step. This will elicit immune reaction with possibly activation of complement system. This will result in some sort of destruction and following inflammation, with further destruction of the glomerulus. The end result is impairment of the renal function that might result into one of the clinical syndromes we mentioned. The ones that we are interested now are nephrotic syndrome and nephritic syndrome. Almost any variety of histopathologic finding can be found in any of the clinical syndrome. So this statement might make you confused, but this is what happens is if you have a clinical disease like nephritic syndrome, there are list of possibilities, and if you have another patient with nephrotic syndrome, there is a list of possibilities. So it is not one-to-one relation. One syndrome might have different diseases presenting with the same presentation. There are broad correspondence between prognosis and histologic finding. That's why histologic finding are important, because the treatment and the prognosis. Each morphologic type of glomerular disease has a clinical correlation as well as etiology and pathogenesis. Okay, let's start with the first syndrome that we are concerned with, nephrotic syndrome. Let's get back to the structure that I just talked about. Basement membrane, on one side there are endothelial cells, and on the other side there are epithelial cells. The blood is contained within the capillaries lined by endothelial cells. Fluids, electrolytes have to pass through endothelial cells, basement membrane, then epithelial cells to enter the Bowman capsule and the tubules to form the filtrate. Okay, imagine there is a very minor insult to this structure, very tiny injury, very minor insult to this structure that result in leak of proteins. Typically, very leak of the small proteins, which is commonly albumin. So in this scenario, minor insult to this glomerulus with tiny leak of proteins at the beginning, albumin, because it's relatively small molecule. Then later there might be leak of larger protein, but let's consider first very tiny insult with leak of protein, albumin, that escape or cross this structure, and there is increased amount of albumin in the urine. So the first feature of nephrotic syndrome is marked proteinuria. Considering that there are millions, estimated 1.5 million glomeruli within the kidney, so the amount of albumin will be a lot if there is leak of albumin. In a typical form of nephrotic syndrome, the amount of protein is 3.5 gram or more per day. So we have to collect 24-hour urine from the patient, and we measure the amount of protein, typically more than 3.5 gram per day. So this is the first feature of nephrotic syndrome. There is loss of albumin in the urine, resulting in proteinuria. The proteinuria is mainly albumin in this scenario. So the albumin in the blood will be low. There will be reduction in the albumin of the blood, resulting in generalized edema, hypoalbuminemia, and generalized edema. So this follows the proteinuria. The albumin level is low, hypoalbuminemia, and the edema results from loss of the osmotic pressure in the plasma, resulting in generalized edema of the patient. What happens in this patient? The liver tries to compensate for the loss of albumin, and the liver starts to produce albumin and other metabolism. So the metabolic machinery starts to be activated in the liver. The liver tries to produce albumin, however, the albumin is still lost within the kidney, so there is no improving the albumin, but there is elevation of the lipids. With the albumin, the liver machinery starts, so there is typically hyperlipidemia, with some loss of lipid in the urine as well, with hyperlipiduria. So this is the sequence that happens in patients with nephrotic syndrome. Remember again, in nephrotic syndrome, the insult and the injury to the glomeruli is really minor, very small minor injury to the glomerulus, resulting in loss of protein. So this is nephrotic syndrome. If you get a patient with those features, you will call the patient nephrotic syndrome. Then you move to the next step to find what is the pathological disease that this patient has that he developed nephrotic syndrome. This is a list of the most common causes of nephrotic syndrome. If the patient is a child, minimal change is the most common cause. If the patient is adult, membranous nephropathy is the most common cause. I mentioned a few words earlier about minimal change. Membranous, not to describe details, but from the name, in this disease there are thickening of the basement membrane due to deposits, due to immune deposits within the basement membrane. That's why it is named membranous glomerulonephritis or membranous nephropathy. Another cause of nephrotic syndrome, focal segmental glomerulosclerosis, membranoproliferative. There are different types of membranoproliferative glomerular disease. We will not get into details. and IgA nephropathy. Remember, IgA nephropathy can present as hematuria as well, but it can present in rare cases as nephrotic syndrome. Okay, back to get you a bit confused, back to the idea of primary and secondary. Remember that even nephrotic syndrome can be secondary to diabetes, amyloidosis, systemic lupus, some drugs like gold, penicillamine, due to some infections, association with malignancy, and other causes like bee sting allergy or hereditary nephritis. So from clinical point of view, if you get a patient with nephrotic syndrome, you see the features of nephrotic syndrome, you first consider primary diseases, then you consider secondary diseases as well. Let's read this scenario. A 5-year-old child presented to pediatric clinic by his parents suffering from swelling, which was noticed around the eyes, legs, and abdomen. So he has some sort of edema, generalized with recurrence of the symptoms. The swelling was noticeable in the morning. The color of the urine had turned straw colored. It is not associated with burning pain during urination. Of course, you need more information to make accurate diagnosis, but from the description of the urine, this is urinalysis with dipstick. Let's say we find high level of protein in the urine. With the edema of this child, protein in the urine, we can check the albumin level, we can check the lipid level, and we may reach to the criteria that satisfies the diagnosis of nephrotic syndrome. Okay, let's in contrast look at this second case. We did not talk about this yet, but just read this case. 6-year-old male child presented to pediatric clinic with burning urination and hematuria. So parents noticed that there is change in the color of the urine with blood in the urine. His mother noticed that the child has 2 attacks of follicular tonsillitis in the previous 3 months. So previously, in the last 3 months, the patient has tonsillitis before presenting with hematuria now. So there is a difference between the first presentation, case 1, and the second presentation, case 2. What I would say, just simply oversimplification, imagine now that the insult of the glomerulus is a bit worse than the first case. In the first case, we said there is minor insult with loss of protein only. Now, some injury happened to the glomerulus, likely immune-mediated injury, but there is breach of the basement membrane. There is some rupture of the basement membrane and the endothelial cells with minor bleeding, leak of blood in the urine. So the patient in this scenario present with hematuria. So it is oversimplification, but you can imagine that the insult within the glomerulus in this scenario is worse than the previously described nephrotic syndrome. So there is injury with rupture of the endothelial cells, with leak of blood in the urine. So the patient developed hematuria. This is the definition of nephritic syndrome. Nephritic syndrome, usually abrupt onset of acute nephritic syndrome, 1 to 4 weeks after upper respiratory tract. This is not definition, sorry. This is just the case scenario back to describe the case we just read. But what are the features of nephritic syndrome? The first feature is gross hematuria. So usually the patient or the child parents notice that there is blood in the urine. If the kidney we mentioned is injured, the kidney will not function normally. So this will result in oliguria and azotemia, increasing level of urea. And the kidney is not functioning well, so there is accumulation of the fluid with a result of hypertension. So this is the typical, these are the typical, the three features, these are typical of nephritic syndrome: gross hematuria, oliguria with increasing urea level in the blood, and hypertension. The presence of proteinuria, remember that if there is blood in the urine, the blood includes protein, so you will find proteinuria, but not concentrated protein like what we described in nephrotic syndrome. But there is large amount of protein, not because there is protein loss, because there is blood loss. So there is proteinuria. If the nephritic syndrome is post-infectious, you might have anti-streptolysin O in the serum, and you might have consumption of complement component with low serum complement component level. So the three features are the typical features of nephritic syndrome. This list is relatively short, but this is the common causes of nephritic syndrome. I like to really combine the first three and call them post-infectious glomerulonephritis, because the common things in the first three causes, it is post-infection. Typically post-streptococcal in pharyngitis or tonsillitis. So typically a child develops tonsillitis and or pharyngitis, then he is cured, nothing wrong. Later on, after 2 weeks, after even cessation of the infection, the patient develops nephritic syndrome. So this is a typical post-infectious, post-streptococcal glomerulonephritis. Not only streptococcal organism cause this, so there are non-streptococcal glomerulonephritis due to other organisms like staph and some other viruses, some relation to hepatitis C and hepatitis B viruses. Nephritic syndrome can be secondary as well. One example is systemic lupus erythematosus, can be secondary to lupus. Okay. Moving on, this slide we will not go into details of pathological finding, but I will just mention quickly some of the highlights in pathology. Most cases of nephrotic syndrome and nephritic syndrome, clinician likes to get into details of the pathological process, and renal biopsy is indicated in these cases. I mentioned earlier there are three different techniques that are routinely done on renal biopsy. The first technique is light microscopy. The second technique is immunofluorescence, and the third technique is electron microscopy. Special stains are part of light microscopy. I wouldn't consider them a different technique. It's part of light microscopy examination as well. So not to give you details of one disease, this is a general overview. On light microscopy, usually there is increased cellularity of the glomeruli, and this increase in the cellularity might be due to proliferation of mesangial cells, the cells that form the connective tissue within the glomeruli, or proliferation of epithelial cells, or proliferation of endothelial cells, or some inflammatory cells, presence of inflammatory cells within the glomeruli. So there is usually increased cellularity. Commonly there is changes in the extracellular matrix, which we call mesangium, the matrix that holds the glomerulus together, we call mesangium. We might do special stains, or typically we do some special stains to see light microscopic examination. Immunofluorescence is done usually to detect deposits of antibodies or complement component within the glomerulus. This picture on the right corner here is immunofluorescence, and you can see the green color, meaning that there is some sort of deposits. I cannot tell you just from looking at it what is the deposit, because we need to check what antibody was in this test. For example, if this for IgA, we will say there is deposit of IgA within the glomerulus. Electron microscopy can also shows immune complex deposits. This picture here is electron microscopy, and you can see the basement membrane, the food processes of the epithelial cells, and the lumen of the capillary and the endothelial cells. So we can see deposits by electron microscopy. Okay, moving on. So we discussed some primary diseases of the kidney, and now we will move to discuss systemic lupus. Again, not into details, it's an overview of the types of kidney disease in systemic disease. The kidney can be affected in different diseases, commonly autoimmune related diseases. Kidney involvement usually affect mode of therapy and response to therapy. One of the common diseases that the kidney is affected is systemic lupus erythematosus. It is renal disease is related or common in patient with systemic lupus. You can read the details of these studies, and there are links of the complete articles in the presentation. A prospective multicenter study published in 2019 in Saudi Arabia shows that examined the pattern of renal disease based on renal biopsy, and they found lupus nephritis was the most common cause of secondary glomerulonephritis in 66% of secondary causes. I cannot emphasize more that renal disease is common with systemic lupus. Renal involvement is variable from mild asymptomatic proteinuria in some patients to hematuria to renal impairment that may require renal dialysis. So patients with lupus have high risk of developing glomerular disease. The clinical picture can change rapidly. There might be discrepancy between the clinical picture and the histologic finding. What happens typically in lupus? Lupus is immune mediated. There is immune complex circulating in the blood, and these immune complexes deposit in the glomeruli, activating inflammatory response and destruction of the kidney with injury to the glomeruli. The histologic type of lupus nephritis that develop depend on numerous factors. So not all people with lupus develop the same renal disease because there are many factors that play. Some of these factors are host related, not clearly understood. Patients with lupus usually have anti-double strand DNA antibody, and these DNA can be deposited as immune complexes, typically IgG. Immune complex promote inflammatory reaction. This results in proliferation of endothelial cells, mesangial cells, epithelial cells, and the matrix with destruction and fibrosis. As I just mentioned, not all patients with lupus develop the same injury to the kidney. So there are different classes. There are 6 classes of diseases in a patient, in disease of kidney in patient with lupus. In class 1, there is minimal mesangial lupus glomerulonephritis, so the change is just in the connective tissue mesangium. In class 2, there is mesangial proliferation. Class 3, there is focal lupus glomerulonephritis. Class 4, diffuse lupus glomerulonephritis. Class 5, membranous. Remember, the term membranous is similar to membranous glomerulopathy, but membranous class 5 is similar to membranous from the pathological finding point of view, but obviously the cause is different. Class 6 advanced sclerotic lupus glomerulonephritis. This is probably the only picture that I'm showing light microscopy. You can see glomerulus, you can see capillaries. These lumens are capillaries, and the blue cells here are the mesangium that holds the glomeruli together. In this picture on the right, you can see there are these focal area of mesangial proliferation. So this is probably fit for focal lupus nephritis. There is focal changes with mesangial proliferation. In this picture on the left, there is more diffuse changes with thickening of the capillaries. You can notice here the capillaries are thick. So this picture might raise the possibility of membranous glomerulonephritis. This picture is immunofluorescence, where there is this green deposits of immune fluorescent material within the glomeruli, indicating immune mediated injury. Lastly, I will leave you with this question. 21-year-old lady known to have systemic lupus erythematosus and lupus nephritis for the last 4 years. Biopsy was done at the time of diagnosis and showed class 4 with active disease but no chronic changes. Which one of the following histopathologic finding will be found in her renal biopsy? So if we do biopsy, what finding we will see in class 4 lupus nephritis? I will leave you with this. I think this is the last slide. This is the reference if you want to get back to. Thank you very much.